I would like first to thank the organizer and especially Dr. Mohamed Mulal for his invitation, and I hope bring contribution to this conference. The title of my conference maybe is not really deeply connected with the topic of the conference, but there is a bridge between the diet, so the food, and the health. So, and when it's a little bit late because of a bad lifestyle or a bad diet, people need surgery, and I will show you coming from a bad lifestyle, people can develop some pathologies, and there is a help in terms of mechanical engineering and computational mechanics to give a support to surgeons. This remote is supposed to work. Yeah. Next. Battery? Oh, okay. Good. Okay. So I just try to forgive me if in the first slides I'm not specialist in nutrition and in food, but I just want to construct some bridge between the food and some dietary choices. The title is Nutrition and Heart Health Issue. Of course, because of dietary choices, people can develop some cardiovascular disease, and it's common to claim that diet is a core of CVD, cardiovascular disease. So, but it's more appropriate to say that there is a certain eating habits which strongly contribute to the development of this disease. And of course, regular consumption of unhealthy foods leads to condition of pathologies. One of the most common CVD is the atherosclerosis. This concerns the hardening of arteries due to bad cholesterol, inflammation, which is caused by saturated fats, sugar, and refined carbs. Hypertension also, diet high in sodium and low in potassium, which leads to water retention, and it contributes to CVD. And other diet-related risk factor is, of course, the obesity, the type 2 diabetes with the high in sugar and refined carbs, which leads to insulin resistance and which damage the blood vessels. The high triglycerides also, excess sugar, alcohol, and refined carbs increase triglyceride levels and contributes to atherosclerosis. Well, increased risk on the left, but I think in Europe it's more common to find people eating McDonald's and hamburger and Coca-Cola and so on. And also we have the possibility to choose a better solution in terms of food. So as a resume for this introduction is that it's maybe simplistic to claim that diet is a cause of CVD, but it's entirely correct to say that your dietary choices are among the most powerful factors you can control to determine your risk of heart disease. Well, I'm going now to talk about something I'm more familiar with. Is of course, the pathology is personalized. Each people have a signature in terms of pathology. That means it necessitates a personalized treatment. And this is the aim of the work we are performing in the lab with my group concerning the personalized medicine and the use of numerical tools with the target of helping surgical plannings. So just to recall that in 2013, the concept of 4P in France, it was 4P medicine is predictive, preventive, personalized, and participative. And in this 40, you can find predictive, preventive, and personalized. Of course, participative is coming from the patient, but our aim is our target is to contribute to the development of this 4P concept. Well, this is a slide showing you the cardiovascular disease, which is the leading cause of death worldwide before the cancer. So this is very important to consider. And this, because of bad lifestyle, you can develop aneurysm in the abdominal aorta or in thoracic aorta, TEA, or we can also, because of the development of bad cholesterol, you can have, let's say, the aortic dissection. The aortic dissection, which is going to be presented more deeply here, is the blood is ruptured in the wall of the aorta by a tear. It's like onion, which peels off the layer of the aorta, and the blood is coming inside, and we will have a false lumen and a true lumen. Okay, so the process we develop in our research is in a deep connection with hospitals. So we work with surgeons, we work also with radiologists, and this is clinical data for a personalized patient, and this personalized patient, we are going to develop, I heard this morning the term of twin, which is a digital twin, in order to represent the aortic circuit, to develop a methodology, virtual methodology for a given surgery. So this is the medical imaging pictures and the virtual representation of aortic dissection. Okay. Here another example we are treating is the regurgitation problem. It's the weakness of the cardiac valve, and instead of pushing the blood from the atrium to the ventricle, there is a reflux, and this is very dangerous for the patient. And this can be repaired. This is especially the mitral valve. This can be repaired with by using a mitral clip device. And many years ago, we use open surgery, which with a very high risk. But now the surgeon prefer to do a transcatheter or transfemoral surgery, which consists of introducing tools, clamping the tools until the area of concern, either the aorta or the cardiac valve. Okay, so this is, of course, I gather all the pictures to show you that we have to evaluate the mechanical properties of the tools, means the catheter, the prosthesis, and so on. This can be done very easily because we are in a lab of mechanics, so we have machines for the evaluation of the mechanical properties of the tooth, but the problem is how to evaluate the mechanical properties of the tissue. So this can be performed by using inverse approach from 4D RMI. I can give you details if you're interested, or also create a mapping from cadaver. We can connect the voxel, so the intensity of the image with mechanical property, creating a data bank, and then we can determine the material properties in terms of soft tissue. So we are going to see now the climbing of the tools inside the artery until the area of the aortic dissection, and when arriving at the level of this aortic dissection, then we are going to release an endoprothesis. This endoprothesis will allow the blood to flow inside the artery more properly, or in the case of aortic dissection, it's going to close the false lumen in order to get a clear position of the artery. You can see here, this is a numerical simulation. Of course, we consider the mechanical properties of the tissue as well as the mechanical properties of the endoprothesis. Well, and we did many simulations, but these simulations are performed in research lab, and we need to validate this simulation. And you can see here a 4D RMI on the left for a patient, 78 years old, and the simulation, fluid mechanics simulation, it's more complex. It's fluid mechanics, and this is a fluid structure interaction. We consider deformation of the tissue, and then we can compare in pre-operative and post-operative time the simulation, and then we can make some validation. With this simulation, we can also, as I said, perform the surgery. You can see here an overview of the preoperative and postoperative simulation, and you can see that we can observe the very local phenomena in order to provide to the surgeon the maximum of information to allow him for a success to his surgery. This is preoperative, postoperative, and with or without the stent. And what is interesting is that we can perform before the surgery. We can perform before the real surgery. We can perform virtual surgery, and we can see what is going to happen after the surgery, virtually, of course. And we have defined some speaker talk about biomarkers. We have defined some numerical biomarkers in order to identify the location of critical zones, which are is how I say a weak and the area where where some pathology can develop after the pathology, because the surgeon have no idea about what is going to happen to his patient after the surgery. This is other simulation and comparison for the validation. Just for your information, we did this validation until now for more than 200 patients, and the Hospice Civil de Lyon, the main hospitals in Lyon, use our our model for the critical cases. This is our simulation, and I talk about these biomarkers which can be identified. Here, we talk about the low wear shear stress. The wear shear stress is the friction at the internal face of the artery. And if you detect some stagnation zone, this stagnation zone can be the location of platelet aggregation, deposition of atherosclerotic plaque. So that means this is a critical zone which can be identified, I said, before the surgery. And this is another identification of numerical biomarker, which is strong washer stress. And a strong washer stress is not beneficial because it's going to damage the endothelial cells. And we are talking here about mechanotransduction. So we are looking for something which is soft. And that simulation can allow us to identify the critical zones. The second example I'm going to talk about is the mitral regurgitation. As I said, this is the left atrium and the left ventricle. And in the case where this valve is not working well, then the blood instead going from the left ventricle to the aorta, the blood is coming back. So this needs a surgery, and this is a big program we have, which is called Iceland Intracardiac Echography Integration in Landing and Annuloplasty Device. And it gathers a lot of labs and hospitals. Well, the surgery is going to be performed. We say transcatheter. Sorry, we say transfemoral transseptal surgery. We are going to introduce all the tubes from a femoral puncture, and all these tools are going to move until the right atrium, because it's going the introduction is done via the femoral vein, and is going to arrive at the right ventricle, right atrium, sorry, and then there is a septum between the right atrium and the left atrium, and then we have to go through this septum, and after going through the septum, we just arrive above the mitral valve. And the reparation of this mitral valve is doing by putting a bandlet, and we say the annuloplasty ring, and it is going to be fixed on the tissue in order to guarantee a good functioning of the valve. Here, another picture. You can see the left atrium, the mitral valve, and the left ventricle. And what we perform numerically is to install the prosthetic headband and to fix with puncture and to test. This is the annuloplasty, and we test that there is no reflex from the ventricle to the atrium. Okay, these are very nice video showing you how it works. The first step is to implement the prosthesis. The second is to downsize, to reduce the diameter in order to check that there is no reflex. The third step is with the help of ecography is to check that the contraction do not change the positioning of the of the prosthesis. And this is a actual view of the mitral valve. And so this is a virtual reproduction of the left atrium. And of course, there is a very big effort which is done to identify the quality of the tissue in terms of mechanical response to forces. And we start, of course, from medical imaging. We represent the geometry, the mechanical characteristics of the tissue. We identify the interaction. The blood is going to exert pressure. There is contraction. We need to identify the boundary condition in terms of forces and displacement. So, the implantation of the prosthesis, this is the simulation, the numerical simulation of the implantation of the prosthesis. I talk about the diameter reduction. Here, you can see that we can simulate numerically the diameter reduction, and this diameter must be ranging from it's around 6 millimeters, depending on the patient. It's from 5 to 7 millimeter, and we need to test the ventricular contraction and if there is any impact on the positioning of the prosthesis. You can see here the contraction, numerical contraction, which is performed on this model. Okay, the aim of this simulation is to check that the anchoring has been perfectly placed to fix the prosthesis by the means of the evaluation of the stresses on the tissue and checking that there is no overstresses which can damage the tissue. Well, how time? 5 minutes? Perfect. This is the last slide. Okay, just to show you the flow chart which is used to predict the or to help the surgeon for the planification. We perform this for cardiovascular disease, also for articular replacement for prosthesis. Starting from DICOM images, we use some segmentation. Then we construct virtually a 3D biofaithful model. When I say 3D biofaithful model, it means it is biofaithful geometrically, but also in terms of mechanical properties of the tissue. This is very important to notice, and it is not usual to find this. And the 3D meshing, this is a numerical simulation, as you have seen. We can make the simulation before the surgery in order to help the surgeon for his planification and to detect if there is any problems during the surgery. And this is some validation we have performed, mainly for vascular disease. Okay, this is the last slide. Thank you for listening. If you have any question.